Hi, my name is Jenna Gripshover. I'm a nurse practitioner and the nurse manager for Cedars-Sinai Liver Transplant Program in Los Angeles. And I am here today to talk to you about non-invasive testing, which is a practical overview and just navigating the basics of how to get a fibrosis assessment on somebody with metabolic-associated steatotic liver disease. So the fundamental difference between MASLD, which is basically simple steatosis, and MASH, which is your metabolic-associated steatohepatitis, is the degree of inflammation. And the difference is that MASH is much more likely and much more aggressively going to progress to cirrhosis than MASLD. It doesn't mean that MASLD can't progress to cirrhosis, but it's just less likely to. And the problem is that MASH, with that inflammation, can give you worse outcomes, and it's something to pay more attention to. So when we talk about testing, we want to try to get a sense of, is there fat in the liver, and is this fat causing problems for the patient that's going to lead to bad outcomes like cirrhosis or other things that we want to try to prevent. So when we talk about trying to figure out how much damage that there is in the liver or how much fibrosis there is, what we're doing is we're trying to figure out how aggressive is their fatty liver disease. Is it, more of an aggressive phenotype, or is it a less aggressive phenotype that we can be a little bit more relaxed about monitoring? So when we use this non-invasive testing, we don't have any good non-invasive testing to really figure out how much inflammation is actually in the liver. We can use liver enzymes to get a sense of how ticked off the liver is, because when the liver is upset, then it can send out these liver enzymes, but that's not a 100% guarantee that if you don't see those elevated liver enzymes, that there is no inflammation, because you can have inflammation without those elevated liver enzymes. So one of the things that we do with non-invasive testing is that we try to get a sense that, is that liver getting stiffer and starting to progress towards cirrhosis? And we use that as a measure of how aggressive their fatty liver disease is. And we can diagnose fatty liver disease pretty easily. Remember, we diagnose it when there's risk factors or cardiometabolic risk factors, when we see evidence of fat in the liver on testing on imaging testing like an ultrasound or even an MRI. And then the real crux of this diagnosis is the lack of any alcohol intake. So we want to look for people who either don't drink at all or they don't have any robust drinking, and get a really good alcohol history. So different non-invasive testing. There is blood-based test or serum-based test, which is going to be tests like your FIB-4 or your ELF score. And then there's imaging-based non-invasive testing, and that's going to be your FibroScan or vibration-controlled transient elastography or your MR elastography. And when we get these tests, again, they have two different modalities. They're measuring two different things. Your blood tests are measuring biomarkers in the blood and basically hormones that your liver's making to measure how much damage that your liver has, because we know that a liver that has more fibrosis is going to make certain chemicals more than others, or make less chemicals versus others. And the vibration controlled transient elastography or the elastography, that basically measures liver stiffness. So it measures how jiggly the liver is, or how well sound can travel through the liver. And if you remember back from high school science, that sound travels better through solids than air. So the more solid your liver is, the more sound's going to travel through it. And the MR elastography can actually measure that. So again, these tests, they don't measure necessarily how much damage is in the liver, but they can measure, and they don't always measure how much fat is in the liver. They can put you in the ballpark. There are some, again, there's a measure that comes up on the ELF score and on the vibration controlled transient elastography called the CAP score. They can give you an idea if there's a lot of fat or not as much fat, but it's not 100%. And so you have to take it with a grain of salt. These tests are a lot more accurate for determining fibrosis. And again, that's really sometimes what you are really trying to assess with these tests, versus we already know the patient has likely have steatosis because we already got the ultrasound before that showed that there was heterogeneity within the liver that was consistent with fat, and they've got these cardiometabolic risk factors. We already know that. So how do you integrate these results into the overall clinical picture? Well, I love that concept because you have to treat the patient. You cannot treat the numbers. So you have to look at your patient. Does your patient have risk factors? Do they have elevated liver enzymes? Do they have any testing that is suggestive of having another liver disease? The diagnosis of fatty liver disease is a diagnosis of exclusion. So you have to make sure that there's no history of significant alcohol intake, that there's no sign of anything else that could cause similar results. So you want to look for autoimmune disease and viral hepatitis. You want to rule all that stuff out. And then again, looking at the patient history, I would be really suspect in getting a patient a referral for somebody with fatty liver disease seen on ultrasound, and they have blood pressure that's better than mine, a cholesterol panel that is better than mine, and no history of diabetes. I would really be questioning, like, okay, is this really fatty liver, or is this something else that looks like fatty liver? And maybe we need to figure out what's going on a little bit more and hash that out a little bit more. But I will say that when we talk about the profile of your typical patient, almost everybody that you're going to get are going to have some risk factors there. And again, if you see the fat in the liver and you've got the risk factors, and again, you don't have the other testing, then you can be pretty confident that this is likely fat in the liver, and we need to address it and figure out how much damage there is in the liver, how aggressive do we need to get about treating fatty liver, and what other things can we do to help improve the quality and quantity of this person's life. And the other thing too that I think is not remiss is that, the initial treatment for fatty liver disease that doesn't have much fibrosis on it. Again, if you can detect that there's no fibrosis with your non-invasive testing, the recommendation is to lose weight and get your comorbidities under control. And that's probably good advice for them anyway. So even if you have a patient come in and you get that FibroScan back, and the FibroScan is showing that there's unlikely significant fibrosis in the liver, and the FIB-4 is showing unlikely significant fibrosis in the liver, you can spend that entire half hour talking about the importance of a 5% weight loss, because that's going to help prevent and get them probably fixing their comorbidities while you're at it, but it'll also help improve the health of their liver. And of course, if there's more fibrosis, then it gives you an opportunity. And we've got some fantastic treatments now, if there is some evidence of progressive disease, that we can help head that off before they get to cirrhosis. Because the problem with cirrhosis is that once it sets in, we don't think it reverses, or it's unlikely to reverse. And they're at risk for all sorts of terrible things like liver cancer and needing a liver transplant. And that's assuming that they're even a candidate for a liver transplant, because if they have comorbidities like heart disease from their diabetes, they may not even be a transplant candidate. And we want to prevent all that from happening. So that's why these tests are so important. And again, they can be repeated easily in an office setting, and it gives you a great sense of how to best manage your patient in front of you. So key thresholds to know for the non-invasive testings. And I advise anybody listening in right now to write it down and tape it to your computer monitor or somewhere where you can reference it very quickly. I actually have my FibroScan assessment taped to the back of my cheat sheet book, because I'm still old school and I still have a book that I carry, where it's gives me an idea of, based off of the FibroScan number or the FIB-4 number, what the likelihood is. But generally speaking, a FIB-4 test that's less than 1.3, then you can be pretty confident that there's no significant liver disease. Again, the negative predictive factor of that is very high, versus if you've got a FIB-4 test that is greater than 2.67, then it's likely that advanced liver disease is there, and you need to start thinking about your cirrhosis screening and assessment at that point. And if it's somewhere in the middle, then you definitely need more testing. The other test that I have when I get a FibroScan back, if I get anything more than a 10, I start to get a little bit nervous, because I think to myself, okay, so we've got a FibroScan that's not normal. It's a 10, and we need to do something about it now. Now, it doesn't mean that cirrhosis is there at a 10, but that's my internal measure of like, okay, we really need to look at this. I definitely talk to the patient. Let's say I get a fibro score of somewhere around 7, and I think a FibroScan measurement of a 7 kilopascals is not normal. And that's something that definitely needs to be addressed, whether it is with medicines or with dietary or comorbidity intervention. That's one of the things that you want to follow up on, and you want to make sure that you're keeping a close eye on that, because we're getting close to getting to advanced liver disease. And with that, thank you so much for listening. And thank you to Gap and Madrigal for making this happen. And if you have any questions, please feel free to reach out. I love questions and I'm happy to answer them.